Okay, so I'm talking about the VBP15. It's now, the generic name is Vamorolone. Just a disclaimer, we're not publicly traded, but this is a drug under development for DMD and in clinical trials. It's an investigational drug and has not shown proven benefit, long-term safety, not clearly demonstrated. Suzanne Gaglianone is here, and there's a booth also with her and Jesse if you have questions. Also some disclosures. I've been working in Duchenne for 31 years now, I think, and so I wear a number of different hats. So just in disclosure, there's different efforts both in the venture philanthropy space and academic space that I'm helping lead. And there's booths for ReveraGen, Agata, and Trins here if you want more information. So the goal of this program is to separate different activities of glucocorticoids, and these include prednisone, deflazacort, and others, and keep or improve aspects of efficacy, so benefit to DMD, and remove aspects of safety concerns or reduce or eliminate side effects. In doing this, we also ended up adding new activities that aren't typical of glucocorticoids, and those are membrane stabilization and antagonism for the mineralocorticoid receptor, which I'll go over in a minute. This is what's called a dissociative steroid. It's not a glucocorticoid, so it is not a prednisone or deflazacort. It has a different chemical structure, and it's considered a first-in-class drug, so there's no precedent for this type of structure before. So many of you have seen some of this before. I'll just briefly go over just a slide or two of background and focus on the clinical trials and their status. Prednisone stunts the growth of mice as it does MDX mice, which are Duchenne mice, as it does Duchenne patients. And Vamorolone, we can go to quite much higher doses, and we don't see that stunting of growth in mice. And the same with the bone fragility. We don't see the bone fragility you see with prednisone. So this just summarizes all the science background. This was a highly de-risked program, so like the NIH independently validated a lot of what we've done, and it's all run by academic medicine folks. And so here I really systematically compare and contrast Vamorolone versus prednisone or deflazacort. So in terms of efficacy, one of the key benefits of glucocorticoids like deflazacort and prednisone is thought to be the anti-inflammatory effect. And so that's why there's 90 million prescriptions of prednisone or other steroids in the US per year. So this is a very extensively used class of drugs, glucocorticoids. And it's mostly for this anti-inflammatory benefit, which is also called NF-kappa B inhibition. You'll hear that also in the next talk. We seem to have retained that equally to prednisone. And since we can increase dose, there could be a potential upside that will have additional anti-inflammatory effect. We've added a new effect, which is a membrane stabilizer, so that dystrophin deficiency, as you've already heard, destabilizes plasma membranes and muscle fibers, and that's a primary cellular problem. And so we know this drug, in a dose-dependent way, counteracts dystrophin deficiency to some extent. A different activity is a mineralocorticoid. That's very hard to say, a receptor blocker. And some of you may have participated or are taking a Plerinone or spironolactone. Now, those are drugs that are used in many cardiac failure conditions, including Duchenne, and they really are quite effective, and they've been shown by a Ohio group to be effective in helping Duchenne hearts, so preventing cardiac failure. And we are very similar, if not almost identical, to a Plerinone or spironolactone. So and that's changed the activity of prednisone. But prednisone actually has an opposite activity on the mineralocorticoid receptor. It's what's called an agonist, which adds to its side effects. But we have changed Vamorolone into an antagonist, which is the opposite. It blocks the activity of the mineralocorticoid receptor, and really has taken a side effect, it looks like, into possible efficacy. And the last is synchronization of regeneration. This gets complicated, and I won't go into it, but it seems like glucocorticoids, well, I can say one sentence. What woke you up this morning was glucocorticoids. So your cortisol, which is your normal glucocorticoid, peaked at about 4 a.m. this morning, depending how much jet lag you had and where you're from. But, and that woke you up. And that's what's called your diurnal hormone. It's also your stress hormone, and it helps you fight stress. But it's also an anti-inflammatory. It's all pretty much the same drug. What we've shown through a whole series of studies is that diurnal effect is actually synchronizing your body and helping the different cells communicate and all stay in sync. And so we know Vamorolone keeps that activity. It's actually helping synchronize cells throughout the body. Then if we look at the safety or the side effects, and most of this, as I put at the top, is a draft interpretation from mouse studies. We have finished phase 1 data in 86 adult volunteers, and we're in the midst of rolling Duchenne kids. So all data is consistent with this, but we haven't proven all these in humans. That's very important to point out. So we seem to have lost stunting of growth, loss of delay of puberty because we've lost adrenal suppression about to 1/10, lost metabolic disturbance and probably this weight gain, and certainly insulin resistance seems to be lost. And we've lost this mineralocorticoid receptor activation and seem to have lost immune suppression, which is different than anti-inflammatory activity. As I mentioned, this is done under a different business model. It's what's often called venture philanthropy. The NIH program independently validated much of what we had done, and they had helped with drug production and formulation. TreatNMD TACT reviewed the program, a very great program run out of Newcastle University in the TreatNMD group that many drug companies have gone through. And this has all been done by community fundraising, so foundations, governments, and to date that's been $35 million. And that's with the foundations like the Parent Project, who themselves has put about almost $1 million into this program. With the drug is sold, they'll get 400% return on investment based on later drug sales. And it's all run by academic folks. So as I mentioned, we finished the phase 1 studies. I've reported that at this meeting last year. We've done a large dose range that was funded by Joining Jack, Duchenne Research Fund, Duchenne Children's Trust, all in the UK, and the MDA here in the US, Venture Philanthropy Fund. And we began the phase 2A studies in July 2016, and I'll go over the different trials that we're in the midst of. I should mention that Paula Clemens runs the 2A studies. She's the study director. Together with the Synergy Group, which you've heard, like in natural history studies, these are sites that have worked together for the last 20 years in different studies, and TRINS, which is the coordinating center for Synergy. And Michaela Guglieri and Kate Bushby are running the phase 2B program that I'll describe. So the phase 2A and 2A extension, I should mention, well, it's 48 boys. It's a narrow age range. It's 4 to 7-year-olds, and they have to be steroid naive, which means they can't have taken glucocorticoids, prednisone or deflazacort. And that's important because we're trying to look at both safety and efficacy, and if a child already has side effects from glucocorticoids and they go off that drug and onto our drug, how do we know where the side effects came from? And so I hope you understand that. Certainly we have plans in the future to extend both to a broader age range and also to steroid-treated boys, but we really need to show whether it works or not, first in a specific, small, focused subset of DMD boys. There's 12 recruitment sites in those countries. The trial is what's called a multiple ascending dose, or a 2A study, which is just 2 weeks of treatment, and then a 2-week washout, and then the children are enrolled in a 6-month extension study and then have the option for a 2-year extension study. So some of the children are already on a 2-year extension study. All patients are Vamorolone treated, no placebo, option to enroll in this 2-year extension study. There's the doses. We go from basically 1/3 of prednisone dose to 10 times prednisone dose. So that's the large dose range. And I've already mentioned who's involved in that, and that's funded by the National Institutes of Health. And this is just some experience from families. There's no muscle biopsies in this trial. The trials all have been designed with both parents and foundation involvement, so we try to really reduce the burden on the families. We actually pick our outcome measures, which is how you see whether the drug's working or not, based on family feedback. And so we're using time to stand from the floor as our primary outcome because that seemed most important to families and their quality of life. All drug dosing is done at home, except for a couple days because of pharmacokinetics. It's liquid formulation, so it's easily adjusted based on the weight of the patient and the size. We reimburse all travel and stay, and we try to provide that reimbursement within 2 weeks. And Suzanne Gaglianone is the parent who also arranges all the travel. And there are no overnight stays in clinic, although just if you have to travel, maybe you have to come the day before. Key exclusion criteria: previous treatment with traditional steroids, as I mentioned, and must be enrolled prior to 7th birthday. In terms of failing screening, really there's only been 1 patient out of 24 that hasn't been able to enroll, and that was because coming in, they weren't able to stand from the floor. And so since that was our primary outcome, that was excluded. We have had some initial screening failures due to what's called varicella antibodies. Because we have an effect on the immune system, we want to make sure that they're immunized against chickenpox. And the chickenpox vaccines aren't great. So what happens is patients can test as if they haven't had the vaccine, although they already have. And so what you do is revaccinate them. And everybody that we've revaccinated has then shown up as positive with antibodies and could then enroll into the study. I should mention at this point, I think we're fully subscribed, which means I think we're about close to enrollment. And some sites have waiting lists now, and I'll talk about the phase 2B, which will start soon. And so those patients can enroll hopefully into the phase 2B. But here's where we stand. We're fully subscribed, about half enrolled. We finished the prednisone dose, so the 0.25, which is third of prednisone, and the 0.75, which is prednisone dose, and then we start the 2 mg per kg per day this coming month, and then we go to 6 mg per kg or 10 times prednisone dose in August. And those are the sites that are currently enrolling. So the 2B is the next trial. I'm not going to show any data from the 2A today, first of all, because it's very early in the study and we've only studied low dose groups to date. The biomarker data has been consistent with the adult volunteers. And the PK data has as well. Phase 2B is considered our pivotal study. That's starting probably October this year. Again, the same age range, steroid naive. In this case, 100 boys. There'll be 30 recruitment sites in 12 countries. There will be 4 arms, a low dose, high dose Vamorolone, chosen from what are results in the 2A, prednisone, and placebo. Now, we did go to FDA and say, with the new approval in Plaza, do you want us to change the deflazacort? And they said, no, stick with prednisone. So we're sticking with prednisone with this. Now, the prednisone and placebo is 6 months only. Okay, so there will only be placebo or prednisone for 6 months. After that 6 months, then those patients are randomized into Vamorolone. So everybody after 6 months will be receiving Vamorolone at 1 of 2 doses. And there will be an option to enroll in long-term extension. As I mentioned, the study directors are Michaela Guglieri and Kate Pushby at Newcastle University, and the European Commission has provided the funding for this. So what is involved in the phase 2B trials is a 6-month trial, 50% chance of Vamorolone, 1 of 2 doses. Once 6 months completed, all boys transition to Vamorolone. This is what's called a double dummy design, which sounds terrible. What that means is you're taking 2 drugs at once, because prednisone is a pill, Vamorolone is a liquid. To blind everything, we have to have a pill prednisone and a pill placebo, and a liquid Vamorolone and a liquid placebo. And so the patients get mixes of these and have to take both each morning. Not mixes, get both, right? You know what I mean? So that's listed there. No muscle biopsies, dosing done at home and morning with a glass of milk. Again, we try to keep the visits down, so it's 8 visits over 6 months, and again, we're reimbursed for all travel and stay. And those are the sites and the countries, although we haven't formally agreed to these yet, so there's no contracts in place. And the last slide is the timelines. So as I just described, we started the 2A in 48 boys, steroid naive last year. We'll be fully enrolled by August. We're fully subscribed, which means all the slots are taken. And the 2A extension, the long-term extension continue. And then the phase 2B is the 100 boys, steroid naive, and that starts in October. And then we have a planned safety study. If we start seeing efficacy, the EMA actually wants us to very quickly do what's called a safety study, and that's in 1 to 4-year-olds, that should be, and then 7 to 18-year-olds, steroid naive. Not a lot of kids, but it's basically to show that the pharmacokinetics is the same, the safety is the same, so we can expand the labeling if it eventually gets labeled. Last slide, we have some innovations in clinical outcome measures. As I mentioned, time to stand from the floor as the primary was suggested as by parents. Extensive secondary outcomes. We're doing an MRI in the phase 2B, but it's a short MRI. It's a 20-minute MRI. The other MRIs you've heard about, what I've heard is almost as 3 hours in a machine. So this is just 20 minutes in a machine, and it's what's called an ancillary study, which means that either the site or the patient can opt out if they have a trouble with MRI. But we do want to include that, and the European Commission wanted us to include that. Registration focused on younger age DMD patients, and subsequent extension of labeling. And all this whole trial is designed on sample size calculation based on what we see with glucocorticoids, with prednisone and deflazacort, because we already know how Duchenne kids respond to those drugs. So we keep on benchmarking the Vamorolone program against what we already know regarding steroids. And then we're using a lot of pharmacodynamic biomarkers, both as secondary outcomes for safety and then for exploratory outcomes for dose selection. And here are the different groups supporting the studies and their different logos. Thanks.